Quick introduction. This is a 56-year-old male who presented with acute gallstone pancreatitis in January of 2014. Subsequently had a cholecystectomy performed, but has persisted with smoldering pancreatitis, abdominal pain, and had a CT scan a week ago that shows a large peripancreatic fluid collection, and we're going to show you the CT scan next. So that's a quick rundown of the CT scan, and with that we'll move the case to the room where...
This is your pretty much your garden variety pseudocyst case. As you heard, he had an attack of acute gallstone pancreatitis about 3 months ago, and he's developed this very large symptomatic pseudocyst. And I just introduced the therapeutic echoendoscope. So we can have the endoscopic image large, and you can make me small. You'll see in the stomach, so swap it so the endo is large. You'll see here there's a little bit of extrinsic compression on the posterior wall of the stomach. And I'm just going to push on down. You can see that compression there. So in theory, it might even be possible to drain this pseudocyst endoscopically. We used to do that in the old days before the advent of curved linear array echoendoscopy, of interventional endoscopy. We're now, of course, doing all of this under EUS guidance, but this certainly would be a candidate for endoscopic drainage as well. This is the bulb of the duodenum, and now let's switch on the EUS. So why don't we have side-by-side EUS and endo? And we're just going to take a quick look here at the anatomy. We've got the bile duct here. He actually had an ERCP done when he presented initially with gallstone pancreatitis. His bile duct looks very thin, so there's not much going on here. His gallbladder, as you heard, has already been removed. We can see some of the pancreatic parenchyma here. It looks a bit lobulated. And I don't know how well that's showing up with our transmission. I'm just going to now pull back into the stomach, and we'll take a look. Take a look at the pseudocyst, and you can see it right here. It's quite large. It's very dark. And we're going to look and see how much necrosis we see inside of the cyst. And there's really very little. You can see the wall of the cyst. And there's very little layering here, maybe just a little bit. But this looks like a fairly classic pseudocyst, meaning it's filled with just fluid and no necroses. And you see that the cyst is pushing up against the wall of the stomach here. There's a transducer. There's a stomach wall. And we'll just pull back a little bit further towards the proximal stomach. And this would be, I think, a good site to do our puncture and place our drain. And we'll zoom in on the interposed wall and switch on our Doppler. Just to be sure we don't have any vessels in between the cyst wall and the stomach wall. This looks very good. So I think we're ready to drain our cyst. Now we have different options for a fluid collection like this. We can certainly do it the traditional way, which is to place multiple, usually 2 or 3 plastic stents. Or we can place a metal stent. We've been using the AXIOS stent, which is the dual flange stent, and it comes in 2 sizes. There's a 10 millimeter and a 15 millimeter. We use the 15 millimeter if there's a lot of necroses and we want to do necrosectomy. So we want to be able to easily get in and out of the cyst with our gastroscope, and we want to have a large lumen so that the necroses can exit the cavity. For something like this, I think the 10 millimeter would be fine. It's really just fluid. The metal stent would have the advantage that it's a larger opening. We don't have to place multiple guide wires. So it just makes it an easier procedure. But of course, one could use plastic stents for this. So in the interest of time, we're just going to move forward here. We do not have the version that's called the hot AXIOS, which is available in Europe, which has cautery integrated into the sheath. We only have the cold AXIOS version, which means that we first need to establish access. And then we place our stent the same way that you would place any metal stent over a guide wire. But we need to access the cyst first, and we need to dilate the tract first. And we can do that two ways. Yes, go ahead.
Can I ask you?
Yes, please.
What's the downside of using a 15 in everyone? I follow your reasoning, but is there any higher risk in a 15 or?
No, not really. Not really at all. I don't think so. You could use a 15. You could. It's just overkill. So I think, a 10 millimeter opening is just fine for this. But no, I don't think there's any downside really. And you could just use a 15. We're going to use a cystotome in this case, but you could also use an F&A needle, pass a guide wire, balloon dilate with a 6 or 8 millimeter balloon, and then you can place your stent. The other way to do it is use the cystotome from Cook. What I like about the cystotome, it's all sort of one device. You don't need to use an F&A needle and a dilating instrument. You can just use one instrument. So it sort of simplifies it one step. There are some drawbacks, though, to the cystotome, and I'll mention that as we go along. But we're going to start by advancing the catheter. It's a 5-French catheter. It's actually the Zimmer needle knife that's also used for ERCP. And this is a 10-French catheter that has a metal ring at the tip. That's what we're going to use to create our tract, dilate our tract afterwards. So the first part is to basically burn our way through the cyst wall with the Zimmer needle knife.
Approved now? Can you use it? Yes, you can, because you're using it. Is it approved?
This is approved in the United States. It's been available for a long time here in the U.S. What we do not have in the U.S. is we do not have the Endoflex, which is a smaller cystotome. And I'm going to show you what the Zimmer needle knife looks like in just a moment. There it is. So you can see the tip on the endo view, and Jeannie's advancing the needle knife. So there it is. That's the needle knife. It's a little bit of a thicker needle knife than the needle knife that you're familiar with, that you probably use to your pre-cut. So it's a thicker needle knife. Go ahead and pull it back, Jeannie. So what we're going to do is we're going to use cautery to enter into the cyst. And once we're into the cyst, we're going to leave the 5-French catheter in place, and then we're going to advance the 10-French sheath. Also using cautery, applying it to the metal ring at the tip to dilate the tract. So we can do all of that with one instrument. So I pulled this back right to the working channel. We're going to look for a good spot again to puncture. And we're at about 48 centimeters from the incisors. This looks like a good spot. And then on the room view, you can see here the handle. And there are two cautery ports here. There's a cautery port here, and there's a cautery port here. And we're first going to start out with the cautery port up here. This is the cautery port for the Zimmer needle knife. And this other cautery port here is for the metal ringed sheath, the 10 French sheath. So the first thing to do is to look for the tip of the needle knife. And this is the first drawback of this instrument, that sometimes it can be hard to see the tip of that Zimmer needle knife, and that's exactly the case right now. I'm having a little difficulty seeing that, and if you have an F&A needle, you can usually see it very well, very clear, and you may not see the Zimmer needle knife that well. You can see on the endo, the catheter is pushing up against the wall, but on the EUS view, it's hard to see. And the reason for that is because it's just the metal at the tip that's echogenic, really. We could also put fluoro on, and so we'll have one image here with fluoro. Let's substitute the endoscopic image with fluoro. We already have fluoro set up, and we'll zoom in, and you can see there the tip of the knife, and I'm just moving that forward. You can see how it pushes back and forth on the wall there. So in this case, because we have such a big target, I think we can just burn through the wall, even though we're not seeing the tip that well. I think the likelihood that we're going to miss our target is very small, but that is a drawback of this instrument, that it can be difficult to see the tip of the Zimmer needle knife. And sometimes we see it very well, but other times we don't. Now the other option would be to say, okay, let's abandon this cystotome because we can't see it so well, and let's just go ahead and use an F&A needle. But since we've got it in place, we have such a big target, I think we'll just burn through the wall and see, and then look for the catheter afterwards. We're definitely up against the wall now. And the first step is Jeannie is going to advance the Zimmermann needle knife out of the tip. And so that's done, and we can look on fluoro. On fluoro, you can see, I'll zoom in a little bit more for you. You can see that the tip has been advanced out. So now I'm going to step on the cautery, and we're going to go in. All right, so we're hot now, giving cautery and moving through. Now I'm in, and I need to look for the catheter. And there it is. I'll take the Doppler off. The catheter is right here. So it's just because, you know, I know it's a big target, so I don't have to worry really about veering, you know, off too much, even though I didn't see the tip, but I'm clearly inside of the cyst now. You can see it's very echogenic now with the catheter in place. The next step is, if we could look at the room view, Jeannie's going to remove the Zimmermann needle knife component, and she is leaving the catheter in place. The 5 French catheter is staying in place, and now she's going to aspirate through this catheter to this syringe here, and we're going to look at the contents, and you can see it's sort of a dark brown, very typical of a pseudocyst. So if you can just zoom in a little bit more here, you can see it doesn't look infected, and it's a dark brown color. It's basically clear. Are you guys able to hear me fine? Yeah, go ahead and take it off. And then we're, no, contrast. Go ahead and inject. Okay, stop. Let's have the EUS large, please, Steve.
More or no more?
Yeah, keep going. More.
More. Reloading? You want more? More contrast going in now.
Yeah. Ken, we're back again.
Excellent. Yeah, the problem with using the public internet. Am I there? Yes?
Yep, you're there.
Okay, good. So what we're doing now is you have the EUS view, and we're injecting contrast now. And we sent that fluid. I think you saw the fluid, right? It was a clear, dark brown, not infected, and we sent that off for an amylase, a CEA, and also for CNS, culture and sensitivity. He's not having any fever or chills, but we always send off for culture and sensitivity just in case. So now let's make the fluoral picture big so that you can see the contrast filling the cyst. Now this part is optional. You don't need to fill the cyst with contrast. Keep injecting, please. You can see the contrast going into the cyst very nicely. The bubbles are very echogenic, so you see that very well. And I'm going to take a snapshot here on the fluoro and X-ray, and you should be able to see the outline of the cyst. It's not that clear. It's a very large cyst, as you know. So our next step
Do
is
you always give contrast?
We don't always.
Are you always giving contrast?
So the answer is
just
no.
for live demos.
In fact, just for the live demo, just to show you, these are sort of the standard traditional steps, but we actually now we're doing our pseudocyst drainage completely without any fluoro, really, because you don't need it. You can see everything beautifully on EUS, and you can control this whole procedure just with EUS. The guide wire is going in, and let's have the EUS large, and we should be able to see the guide wire first on EUS. There it is. So it's right here. So you see the guide wire going in?
Beautiful.
And of course it flops around a little bit, so you have to, capture the plane. And once the guide wire is in, we could look at this on fluoro as well. So fluoro large, please. You can see that the guide wire is looped like this. Now our next step is to dilate the tract. So this is the part that's a little tricky. Takes a little bit of some training for the staff. Basically, we have to advance the 10 French sheath while pulling the 5 French catheter back. And you don't want to pull the 5 French catheter back too far because you don't want to have that step off between catheter, and that Zimmern catheter extends 10 centimeters outside of the sheath. So she's got about 10 centimeters that she can pull back. If she pulls back 10 centimeters, that catheter is back inside the sheath, which we don't want. So I'm advancing now, and she's pulling back. This is really a 1-to-1. And I'm going to stop as soon as I feel resistance. So now I'm coming out, and I'm up against the wall. And now also on endoscopy, you should be able to see the gray of the 10 French sheath. And there it is. On the endoscopy, you can see it's a little hazy, but there's the 10 French sheath there. It's up against the wall, so we're in good position. So endoscopically, we're in good position. On EUS, Michael, can you hold the scope like this? On EUS, you can see the guide wire in good position. And now we're going to make the second port hot. So we're going to use cautery to burn through the wall of the cyst now. Once again, it's important to watch that guide wire very closely. This is the tip of the 10 French sheath, and if you want to control this on fluoro, you can do that as well. And you can see right there, there's the 10 French sheath. The tip is very dark because it's metal. All right, so now we're ready to burn through the wall, and I'm going to give cautery and advance. And Jeannie is hot. And I'm through, and I felt it give. And once it pops through, there's a feeling of it popping through, and you can also see the bubbles from the cautery. And then on fluoroscopy, you can see that I've advanced into the cyst. See? So it's moving into the cyst like this. All right, so now we are ready to go to the next step, which is to exchange all of this for the stent sheath, the AXIOS sheath. So we're going to do an exchange, leaving the guide wire in place, removing the cystotome, the entire cystotome. And while I do this, let's have the EUS picture large, please. I'm going to keep my eye very carefully on the wire, on EUS, so that I don't lose it. And remember, as soon as that sheath comes out, what's going to happen is the wire is going to want to go off to the wall. Right, because the wire is now sort of freely floating inside of the cyst. We no longer have a catheter to hold it into place. Now what's interesting is if you look on fluoro, there seems to be a bend at the wire where the wire exits and goes into the cyst. And that means that there is some angulation here in the wall. So we need to be careful about that when we advance the AXIOS sheath. So the first step is going to be to remove the cystotome, and then we're going to see if we can straighten that angle out. Remember, when we look on fluoro, we're seeing it only in 2 dimensions. Also on EUS, we're seeing it only in 2 dimensions, but we have a 3-dimensional structure. And it's a little confusing here because when you look on the fluoro, you can see there's this bend where the wire goes into the cyst. So ideally, we want to see if we can find a way to straighten that out. And what I'm doing is just sort of moving this around to see where the wire is and to see if I can find the best place to advance the AXIOS. Let's see what that looks
The
like.
cystotome had the same bend when you went in, eh? Did you push in a little bit? Are you just pulling back now, or?
Cystotome is now completely removed.
Okay.
And I have only the guide wire in place. But I do have that funny turn there. Do you see that turn, Paul? There's a little bend.
Yeah.
And that part is a little bit of a red flag here, to be careful, because what can happen is that I may end up pushing the cyst wall away from the stomach wall. So that's sort of a red flag that we've created a little bit of a tunnel maybe in the wall itself. Even though on the EUS, if you look here, there's the wire. On the EUS, it looks like it's straight here. Now this is the AXIOS sheath, and I'm going to introduce it over the wire into the working channel, and we'll just push it all the way in. And what we want to be careful about in this case is that we don't end up pushing the cyst wall away as we're trying to advance into the cyst. So right now the best spot is here in terms of seeing the wire. This may not, of course, here, we don't see the cyst that well. So this is the handle of the AXIOS system, and I'm going to unlock. There's a lock and unlock. I'm going to unlock the sheath. This is the hub that advances the sheath forward here. So I've unlocked this. This is the other hub that releases the stent, and you can release the distal and proximal flanges independent of one another. And what I want to do, though, is be very careful, and then we'll push through, and it goes through easily now. So on EOS, you can see the sheath advancing. Do you see it there? And then we could look on fluoro. We have the fluoro view of the sheath, and now we're ready to deploy the distal flange of the AXIOS stent. So if you can make this large, please. So here you can see this is the lock and unlock of the sheath, and we're now going to lock this. So this is now locked. And now we're going to take off this safety, this yellow pin here. So I'm turning this towards you so you can see this. So I've taken the yellow pin and I'm going to unlock this part. So that's unlocked. And I'm going to pull the hub up here to this mark. It automatically clicks. And when that clicks, the distal flange and only the distal flange will deploy. All right, so now I'm pulling back. And on EUS, you're going to see the distal flange deploy. And there it is. And it's very echogenic. Yeah. You see it there. Very echogenic.
Yeah, very clear.
And this is still the saddle portion, but it's compressed inside the sheath. Now, I am going to pull back and switch to an endoscopic view. Now, it is possible, in fact, I do it this way, but for demonstration, I'm going to show you the conventional way, to just deploy the whole thing under EUS guidance. And if you did that, you would just pull back now until the distal flange changes its shape from a disc to a football, American football. And so it becomes more oval, and then you're ready to deploy the proximal flange, which deploys actually partially inside the working channel, and then that is deployed in the stomach lumen, all under EUS guidance, and then you pull away. That's for the advanced, okay? That'd be for you, Paul, if you wanted to do it. This is the beginner's way, so we're going to switch to the endoscopic view now. So let's have the endoscopic view, and I'm going to pull back until I see the white catheter sheath, and wait till I see the black mark. And in a moment, you will see that black mark. You can see it right there? Once you see that black mark, you are ready to deploy the proximal flange. So I'm going back here. I'm going to unlock this again. And I'm going to pull this back. And so you're going to look on endoscopy now. I'm pulling back, pulling back, pulling back, pulling back. And now the stent is deployed, and I just need to push it out a little bit. There it is. It popped out. And you can see the cyst contents flowing. So we're going to leave the guide wire in place now. Okay, so I'm pulling the guide wire out. There you can see the nose cone. That's the tip. That nose cone, by the way, on the hot AXIOS has two wires that run on the side. Those are two cautery wires. It's not like the cystotome that has a metal ring on the tip. It's got two wires, and those two wires allow you to penetrate through the wall without any collateral cautery damage to the tissue. So you basically don't even see a burn mark. The cautery is just to allow you to get into the cyst very easily. So it's cautery that's almost unnoticeable. And it also allows you to get in very easily.
Ken, this is Vinay. Vinay Dheer, hi.
Hi, Vinay.
Can you hear me?
Yes, I can hear you.
Hi. So Takao showed hot AXIOS in the afternoon, a choledochoduodenostomy. And that was, so we saw the hot AXIOS in the afternoon.
That's wonderful. Congratulations, Takao. I wish I could have seen it. So maybe I could watch your video. So we're going to dilate this tract now very quickly to 10 millimeters. This is a 10 millimeter stent. And as you said, Paul, you could have used a 15. It's just that we've got some 10s that we use for the gallbladder and we use for the bile duct. And we'll use it for pseudocysts that have only fluid collections. And then we have the 15s that we use for cysts with necroses. What I'd like to do is go over to Dr. Bhatt's room, Yasser's room now, and then I'll have you come over to me in a moment when I go inside of the cyst to look inside.